on to moderate the conversation, we have Michael Nochomovitz, the founder of Health ContXt.
Good afternoon, everybody, and welcome. Do I have the microphone in the right place? Can everybody hear? Okay. Well, the topic of our session this afternoon is the state of connected health in 2018 and what the future holds. My name is Michael Nochomovitz. My background, as some of you may know, is in system development in large organizations, first in Cleveland and more recently in New York Presbyterian. Health ContXt is a new company that I've set up, which is an advisory group. I'm on the faculty at Weill Cornell. So I'm trying to leverage personally the lessons learned from working with a few thousand doctors over the years and multiple hospitals and implementation of technologies. We have a great panel here this afternoon, and I'm going to ask each of them to introduce themselves briefly. And we'll start with Dr. Ashish Atreja. Ashish.
Hi, everyone. Is my voice okay? Yeah. I'm Chief Innovation Officer in Medicine at Mount Sinai Health System. I direct App Lab, which is our in-house innovation lab for the last 5 years. Before that, I was in Cleveland Clinic implementing, which you all guys love, Epic Inpatient. So it's great to be here and talking about the journey which we went through, completely adopting digital medicine tools. I practice 10% of my time as a gastroenterologist.
Hi, I'm Ben Patel. I'm the Chief Information Officer with Sinai Health System in Chicago. And I've been in healthcare IT for about over 15 years. And prior to that, I was in non-healthcare fields. This is a good topic, connected health. I don't know what it actually means. I think there is no standard definition, so I'm actually going to talk about more what I know about connected health and possibly learn a lot, from all these gentlemen here.
Great. Hi, I'm Sundeep Desai. I'm the Chief Health Information Officer for the Valley area of Sutter Health, and in Northern California, we're Integrated Healthcare Delivery Network. Internal medicine and clinical informatics by training, and I guess my claim to fame is probably that I've been using Epic probably for longer than most people I run into. I started it in 1996, way back when it didn't even do probably a tenth of what it can do today, but it's evolved, and we've tried to keep up with all the innovations that it's had, but excited to be on the panel and hopefully learn and share some of what we're doing and what everyone else is doing.
I'm John Donlan from Steward Healthcare, and for the last 10 years or so, I led Steward's accountable care organization, or Steward Healthcare Network, our ACO arm or division of our company. And we developed our model in Massachusetts over the last 9 years, and now we've just entered 10 new states where we're looking to replicate our model across the country. And our model's largely based on a community-based, largely private practice accountable care organization solution for many of the markets in the United States that are looking for a solution to wrap an organization around private practitioners and pull them into the new paradigm of healthcare. So I'll bring that perspective to the conversation.
Thank you. Well, we're going to kick off with 4 directed questions, possibly 5. We're going to invite audience participation at the end. And we're going to ask the panelists to comment in a few minutes on their perspective on these topics. And given the fact that we're talking about connected health, the most important thing in connected health is the data associated with that connectivity. And so we want to talk a little bit about the management of data for connected health. And I'm going to start off with Sundeep. We're going to start with you. But everyone on the platform and actually many in the audience are responsible in some way for investments in data collection and certainly the use of data to connect patients, providers, and services. So what are some of the most effective strategies you've taken to advance the useful management of data flow for providers and patients within the organization? Some of the things that you've done to make data actionable by providers and useful for patients.
Great, thanks. I'll focus on the last part of that question, which is how we've used the data in an actionable way for our physicians. And this is an example from our ambulatory setting, and it's actually something we started probably about a decade ago. And it's to help physicians with their medication refills. In this era of focusing on physician burnout, we're very attuned to trying to reduce the burden of work for our physicians. And one thing we hear constantly is their in-basket is overwhelming. And a good part of that is the prescription refills that they have to do. So what we've done is come up with a program where this was custom programming because Epic didn't have this at the time. But it takes data from the electronic health record and helps physicians with refilling particular meds. So we came up with initially a list of probably about 30 to 40 medications that were commonly refilled, and it takes, there's protocols developed for each one. So for example, for a blood pressure medication, it goes through the chart and pulls data such as the last visit date, the last blood pressure, last key laboratory values that would be needed for that particular medication, and then it synthesizes it and reviews it and gives it a pass-fail. If all the parameters are within limits, it would pass the protocol, and the physician wouldn't even need to see it. It then goes to a nurse pool, and they would refill it. If it didn't pass, it would go to the physician, but with all of that information synthesized and highlighted to say why it didn't pass the protocol. So they can easily adjust whatever needs to be adjusted or order what needs to be ordered and still refill the medication for the appropriate amount of time. So I think, for us, that was one example of how we made the data actionable for our physicians to try to reduce burnout.
That's great. Thank you. Ashish, do you want to comment now on actionable data and how you've approached that at Mount Sinai?
Sure, I'll share a very interesting story. We do a lot of work in mobile app development for the last 5 years. And when we first came with kind of a remote monitoring app for IBD, inflammatory bowel disease patients, we got so excited. We had a focus group of physicians, and we showed all the data that's going to come back from the patients. And no one was thrilled except me. And I said, what's going on here? They said, we don't want to see the data. And I think that's a reality. I think there are two major assumptions we make about connected health data that I really want to kind of say that may not hold true. There is no extra time for physicians to review the data. And we have never been trained in our medical school to look at this data. So to train everyone to look at the data, to give time to everyone, is really a logistic nightmare. So that led us to actually get a population health coordinator, which was an MPH person. So they looked at the data coming back, which physicians were not used to, and then create a workflow within Epic just when it was the right kind of a decision to be made, then you just send an Epic in basket. So we used a person, but more and more we are seeing that is virtualist, remote monitoring people, maybe within your organization or maybe outside your organization, like Medtronic does it. So when you are thinking of connected health, don't think that you have to burden your physicians. If you haven't solved the problem of someone else looking at the data, you're not going to get acceptance from the physician. The second part, myth which we had was all the data has to come to the electronic health record. When we started, Epic did not even have field for most of the data that we wanted to get. So every data has to be in a flow sheet, and we have to create those flow sheets and all this logistic nightmare. So more and more health systems are now actually putting the data into a data warehouse in the back end and let some triggers come. Our data is integrated with care management dashboards if you have a big population health strategy. So I think there are other ways when you have the data coming much more than working out, just to get into Epic and face the physicians.
Yeah, I think it's a great point. I particularly like the notion of that Ashish raised the concept of a virtualist looking at the data. I have a particular interest in that with the concept of the medical virtualist that we published an article on, and it actually received a lot of negative press from some traditionalists who thought that physicians should be able to deal with data, and what's this business of having people who are only going to triage information and not actually see patients in an office. But I think you're onto something. Can we, let's go on to John. John, do you want to comment on some of the ways that in your world you've helped to actualize data?
Yeah, sure. And I'd love to start off sort of at a real macro level. So I think part of the woes that we have nationally in our healthcare system are a result of how healthcare is financed. So that's not a new idea. That's, I think, something we're all struggling with. So the function of healthcare will often follow how healthcare is financed. And then if you want to change finance, you actually have to change the data. So you have to, so finance actually will follow data a lot. And so it really does get back to, if you're going to change how healthcare functions, you got to get the hands around the data. And so of all the woes in the healthcare system, and we certainly haven't begun to solve all of the issues out there, but one of the issues that we think is part of the solution to healthcare is to get a lot more physician accountability into the day-to-day and week-to-week and month-to-month operations of healthcare. And so we, to get, and I think in the system we need more consumer accountability, we need more provider accountability, we need more sort of industry accountability. So, but we focused our efforts on getting the data so that our physician leadership can hold our physician network accountable. And keep in mind, our ACO model, it's not an employed physician group model. We're largely a private practitioner model. So we don't have sort of an employment leverage. We have an accountability leverage system. And the way we do that is, one thing that we did really well in Massachusetts, and we're working on it in the other 9 states, is we insist that we get all of the payer data. So there's no major contract that we have now for which we don't get 100% of the payer data. And then we combine the payer data with the EHR data, with the Quest data, and then again, because we're a private practitioner network, the private practices don't need data reports and they don't need access to the data. They just need whatever gaps are necessary that they're going to be held accountable to be fed into their EHR so it can be measured, so that we can reduce the hassle factor for them, hold them accountable, and then measure it at a global level. So those, that's really, I think, what we did well in, in our first phase of this was get all the data aggregated, figure out the gaps, but not make it the problem of an individual private practitioner. Just feed it into the EHR so it's just built into their practice flow.
Thank you. That really resonates with this notion of unburdening the physician with and the physician's support staff with a mass of repetitive administrative tasks and data, a sea of data which is data rich and information poor. So I think that's been a theme even at the round table that we had earlier, where people were talking about how to manage the information to make it meaningful for physicians and providers. I think that's a theme in any conversation today on connected health. I'd like to focus a little bit more on patient or physician-centric digital innovation. We hear a lot about apps, we hear a lot about virtual health and telehealth, and I think it's worth spending some time on this topic because it's an exploding field. And on this one, we're going to start with Ashish. If you can perhaps give us some examples of targeted digital innovation which have occurred to connect providers and patients, preferably which have either shown promise of improving quality or financial performance, or have actually shown improvement in quality, financial performance, or even patient or physician satisfaction. Are there any specific targeted digital innovations that your organizations introduced or that you're aware of that met these criteria?
Right. So I can give examples from external organizations, some our experience as well. So there was an article published in JAMA. We talk about apps, and we're all aware of WellDoc was the first app that ushered the field of digital therapeutics by connecting the glucometer through Bluetooth, and then on the back coaches and AI, and that led to a reduction of 1.2% HbA1c, which is average sugar over 3 months, and that was exactly the same as $1 billion drug, which came FDA approval 3 months ago. So that ushered the field of digital therapeutics. Now we are seeing payer therapeutics, which is getting approval for addiction. different kind of opioids to other addiction. We saw Abilify, which is a microsensor within a medicine. So you not only know when a person has taken the medicine, but when a person poops out the medicine. I'm a gastroenterologist, so I talk about poop all the time. But the same microsensor has shown 90% of patients with hypertension get controlled by real-time monitoring, which is amazing. So we did similar trial of remote monitoring, connecting patients who were hospitalized. And I'll talk about challenges in the next thing. We found for any new technology, patients have to be activated first. And if they are in the ambulatory setting and you equip them with an app, especially with a wearable device, there's just not enough time, especially in a busy New York City kind of office. So what we found, hospitalized patients are ideal, right? So they are getting bored out there. And if you actually leverage them to activate at there, equip them with wearable devices, the best part is not only you equip them, you have enough time in a couple of days to see they're using it or not. So you start this habit, power of habit pattern there. So we did that for heart failure patients, connecting them with Bluetooth blood pressure machine and weighing machine, showed them we were able to achieve 40% readmission reduction within 30 days. And the magic was not just patients testing it. The magic was we got the same nurse practitioner dedicate 10% of her time so she could actually look at the data and actually take action items. Because if we don't link, there's no value of remote monitoring if the right actions are not going to be taken, right? So I think, so that was, I think, a very good learning for us. And we really feel it's a game changer how we can actually now approach every hospitalized patient, irrespective whether it's a heart failure or other diseases per se.
Yeah, thanks a lot. I mean, it's just great to hear of prototypes or models or pilots where you can see a definitive change for patients and for doctors, because these will be reproduced and they'll be tried out by others and scaled. John, do you want to comment on any of the innovations that have been targeted for patients or for doctors in your sphere?
Yeah, sure. And again, I'll start sort of global and then go down to a specific. So I think, again, related to how we finance healthcare in the United States, one of the big issues is that sort of behavioral health, substance abuse, and acute care are separated, and they're not connected. And that's largely because the financing of the care of physical health and behavioral health and substance abuse is disconnected. And so I think a lot of the technologies that we've been looking at have largely been to how do we better serve a Medicaid population that has the higher degree of mental health issues and substance abuse issues. So one of the things that we've been doing is trying to empower individual consumers to help themselves get access to certain organizations that can help them deal with certain social determinants of health. And so there's now an app we're using in our network that they can, depending on the need, if they're housing unstable or need access to heating oil or food or mental health services or opioid treatment, they can enter the zip code and in addition to knowing who their primary care doctor is, they can be connected to social services in their community. And that's helps sort of triangulates what normally would be 3 or 4 different conversations to get this information. So that's one piece. Another one is sort of using big data to identify unstable housing. So sort of using algorithms to help us identify those that are either homeless or housing unstable through access to either credit card data or address data and such. So those are sort of 2 additional data points that we use to help better serve our Medicaid population.
Great. Ben?
So finally, I'll give you 2 examples of what digital innovations that we're working on. One is in production. Similar to Ashish, we have a wearable device IoT strategy, a project where we have given up continuous glucose monitors and Fitbits to patients, and we get real-time data directly into our EMR and to our EDW. And so what we did was to adopt the whole project. We looked at it from a people process technology, and we deployed our care coordination, our community health worker model into this whole workflow. And the way we optimized the process for the physicians was we basically only alerted physician when there was an intervention needed. And so alerts used to go and handled by the care coordinators, but this was a real-time data feed from the patients directly, and we built our own algorithms based on the socioeconomic data that we had. So we had a huge repository of socioeconomic data for patients that we had collected. So we were leveraging that to come up with a risk score. And then we were doing health risk assessment on those patients. And then the clinical phenotypes that we gathered to these devices, we combined those and created alerts and interventions. On top of that, what we deployed is a community prescription technology where we can prescribe these patients who are in an urban health setting on where to go, where to eat, where to exercise, and then based on that, we used to refer them for nutrition, consultation, for behavioral health consultation. So we saw overall our no-show rates decreased by 20%. We saw an average A1C, positive. At the same time, we saw the physicians' reliance on the data that they used to do using the scorecards and dashboard went less, because then they knew in real time what's going on with the patient. And we used to send physicians some of the information on the patient and very personalized through the apps that we deployed. So we deployed 2 apps, one for what we call Sinal GlucoHealth, and then the other one's Clinical Care Companion, where we were sending targeted alerts to the physicians and designed by the physicians. So those are one. And the other project that is still in the lab, it's called epigenetics, where we're trying to figure it out based on the saliva of a patient, what's the smoking history, alcohol abuse history, and mortality. And we're trying to do that from a population health perspective. So those are the 2 from an innovation standpoint that we're working on.
I mean, fascinating and really sort of meaningful. Sundeep?
Sure. Yeah, we've got various projects going on that are technologically innovative, but rather than discuss those, I think I'm going to focus on one that's been a little more recent that I've been involved in, and that's been to try to develop something to capture patient-reported outcome metrics. That's getting a little bit more popular these days in terms of different programs wanting these types of metrics and data. And at the time we started down this path, about a little over a year ago, there weren't great tools available to use to capture this. So our research and development department actually developed their own. It was a little more complicated than initially thought, because they had to not only develop the app to capture the data, but then all the back-end systems to collate the information and do the analytics on the information, and eventually try to get it into the EHR to make it more usable. So I think from my perspective, I think that's going to be a very exciting area going forward, and very much looking forward to being able to utilize that type of data in addition to our traditional metrics that we capture about complications and success rates. I think this will be a lot more informative about how successful the procedures were from a patient's perspective. So that's a good way, I think, to capture and connect physicians and patients.
Thanks. I want to change the topic a little bit, because whenever you talk about data and connected health in healthcare, you can't but address the issue of electronic medical records that have become the repository of information, and we were able to digitize most health records in the United States, but now are faced with a whole lot of data and perhaps less information, and a whole lot of very frustrated practitioners. So I'm going to start with John. And John, if you could tell us a little bit about the strategies that your organization is using to address the issue of physician burnout, with the use of EMRs, what you're doing to alleviate this situation, which has really become somewhat of a crisis in the country. And then you can give us a little bit of the crystal ball about, well, what's this EMR going to look like in 3 or 4 years' time? And what are the things on the horizon that are going to knock this out of the park and give us completely new paradigms?
Sure. Let me start with physician burnout, because I think there's there's multiple flavors of it. And some of the flavors sort of relate to how I think ACOs are developing in the country. So there's let me speak to burnout in terms of ACOs. So there's sort of tertiary academic medical center hub and spoke model ACOs out there that, and they'll often be on, sort of one EHR and predominantly an employed model. And I think there's burnout there that relates to being, that comes inherent with being employed or connected with a large system that's sort of slow and it's like a behemoth and there's so many committees. So that's sort of like one flavor of burnout. Another flavor is there's these even sophisticated employed physician group ACOs. And so it's just a big employed physician group. They're also just on one EHR, and then there's just like 12 to 15 minute, every day going in, burn and churn these appointments, and I think that's a burnout. And then they're layering on top of that all the expectations of closing quality gaps and coding accuracy and referral management. And then I think there's another flavor of burnout where private practitioners across the United States, they're feeling left out of the whole ACO movement, and they don't have anywhere to go. And so, they're on some antiquated EMR, if they're on an EMR. Many of them are not. So it's, do I retire? Do I get it on EMR? Do I have to go get employed? This whole industry of private practitioners is at risk, and so I think there's private practitioner burnout. So I think there's multiple flavors of that. I can speak to what we have tried to do for private practitioners, and that is, and this actually relates to what I think is going to happen with electronic medical records down the road. And actually, let me start with that, and I'll go back to the docs. I think in a few years, all electronic medical records are going to be on your phones, and we had a breakout session, we talked about this, but it's going to be, here's my medical record, and I don't care what system you're on, doc, this is my record, and your system better align with this, right? And so Apple's moving there, or there'll be a bunch of, some big deal that for an app to go on the Apple phones, but whatever, that's going to be the medical record. And so I think what we, as a nation, so Epic will be a solution back to the EHR solutions. It'll be a solution for some systems, or for large employed groups or large integrated systems that can afford that. But most of America is not that. Most of American healthcare is small communities, mid-sized communities, working class communities where there's a lot of private practice docs that have nowhere to go, as in terms of being part of an accountable system that's adopting a new healthcare paradigm. So what we've been trying to do is to say, there is a solution out there, and you don't have to be on a specific EHR. You can be on any of these 5, 10, maybe even 20 EHRs. And we'll figure out how to integrate that data for you. So we'll reduce your hassle factor because, one, you can stay in private practice. You don't have to become employed. Two, you don't have to switch your EHR necessarily. Many of them, if you're not on one, yeah, you might have to get on one. If you're on a really broken one, you might have to get on a better one. But now we're going to ask our technology partners, one of which is in the room, to figure it out for us, to say, we don't want to tell our docs to change. We want to reduce their hassle factor, let them focus on practice, and then, as I mentioned, get the payer data, integrate their EMR data, get the lab data, and then push out just the gaps that we want them to hyper-focus on, and no more and no less. So, and we actually think eventually that might become a predominant model, because the other thing I believe is physician satisfaction overall nationally will increase if there's a healthy balance between an employment model and a private practice model, right? I think if we went to one national healthcare system and all docs are employees of the government, I think physician satisfaction would plummet. I think if all physicians became employed in the nation by a private company, I think physician satisfaction would plummet. I think many docs want to be employed, many docs want to be private practice, and there needs to be models for both. There's a lot of good models for an employment model. There's not a lot of good models for private practice, and that's what we've been trying to fill.
Thanks, John. Ben?
Sure. So the physician burnout, I mean, I think all of you guys know, what we are doing from a burnout standpoint is offering them the normal solution that most health systems offer, like Dragon and voice recognition. One of the things that we're working on is creating a work list for a physician so that a physician doesn't have to remember where to go and what needs to be done for this patient visit. And then the other thing we're trying to do is have a patient profile, a summary. So the physician does not have to go and look what happened to this patient. Let me find out if this patient has hypertension or not. So kind of creating the one-page summary so the physician gets it. As soon as the patient walks in, the physician will see what happened, what's going on, and then he or she can then take it from there. So those are some of the things that we are doing. Going forward, we're trying to see, I think in the future, I think more AI, artificial intelligence, is going to take away a lot of the repetitive and memory-driven tasks from physician, and that's some of the things that we are working on. How can we do that? And we're working with technologies, vendors in our own in terms of whether it's deep learning or whether it's truly AI.
Sundeep?
Sure. I think on this topic of burnout, just like all of you guys, we've been trying to crack this nut as well. But I think it's going to come down to eventually, finally, finding a way to minimize the extra work that the physicians have to do that doesn't require a physician. We've been talking about it for a long time, but not too many systems have been very successful at actually doing that. It's difficult for multiple reasons, but I think that's what it's going to take. So to that end, one thing that we're trying to do is get a better understanding of what is causing the burnout. So we participated in that class survey. This year, class did a survey for the first time where there's, I think they had about 55 organizations participate, and we actually can benchmark against the other institutions on how satisfied our physicians are compared to other physicians across the country. In addition, we've got a lot of other data that we get from our EHR vendor and other reports that tell us how much time they spend in Epic, how much time they're spending after hours doing their charting and other work, and try to match up some of that data to really understand what is driving the burnout. Because it's not yet clear from our preliminary look at the data that any one of those metrics will tell you who's going to get burned out. Just because somebody's spending evening hours doing their work in the HR doesn't necessarily mean they're going to get burned out, right? They may have wanted to get to their child's soccer game and did their charting later, and that may make them happier that they were able to make that game. So we're really trying to get a better understanding of what's driving the burnout, and then putting the programs and tools in place to support those findings, and then minimize that extra work that the physician's doing.
Thanks. Ashish?
I was thinking how to save myself from burnout.
They don't have burnout at Mount Sinai?
Too much, huh? So I think first is I would like to say it's not physician burnout alone, it's also nurses burnout. We have to really look at the entire care teams. The way we practice is so inefficient that it leads to the same thing again and again. If I was doing intellectually rewarding work, I may not get that much burnout as doing the same things. So I think we're finding, first is we have partnered with our HR resources to create a wellness toolkit for all our employees, 35,000 employees. And we are prescribing them apps. So we partnered with Deepak Chopra, there's a Jayo app. So we prescribe smoking cessation, Jayo app, mindfulness sessions. So people sometimes feel it's not just work alone, there's other things you can do. And we track every single thing. And we'll talk about the digital medicine platform. So we can say this person is engaged with it and those kind of things. The other part is automating. There's a robotic process automation. That's technology is now coming mainstream, where you can automate many parts of the stuff. For example, for nurses, a lot of the burnout is just calling. They are being delegated like secretary, right? Whether it's a post-discharge reconciliation or taking the calls. And what if most of the health systems who have even MyChart or any patient portal have less than 15% adoption or 20% adoption, really meaningful. So we are bulk prescribing MyChart. So the more you get to secure messaging, the more you let go the phone part. The more you do self-service things, making appointments on their own using ZocDoc or their online thing, those all things which are repetitive, you can actually take it out of the equation and really decrease the workload. I wouldn't say we have figured it out, but we're looking at a multi-pronged strategy across all the care spectrum, how we can automate things and then cut across it. The same with billing as well, using AI to kind of drop the codes earlier rather than having someone just go through it manually or not able to figure it out.
See, the other thing here, that when we talk about burnout and we focus on EHRs, because EHRs always appear at the top of the list when you do these surveys, it's not just the EHR. It's the structure around the EHR. So, EHRs don't solve workflow problems. EHRs don't solve staffing problems. And depending on where you are, I think mistakes are made repeatedly in not creating a workflow which is appropriate for an EHR, which entails making sure that the doctor and the clinicians are not secretaries, and that people are doing the manual work, and that the use of the EMR can be optimized in terms of digitizing health records. We don't do that as a nation right now, and it's a terrible dilemma because we've really messed up the doctor-patient relationship. So this is one that's, you're going to walk out of here with a big question mark. Let's turn to our fourth topic. It's one of my favorite ones. And, we talk about data and we talk about how to report data. We're now in an era where we're not just talking about data, we're talking about what can we do with the data and what can machines do with the data, and how can we make our lives simpler, both in clinical and administrative functions, using deep learning and artificial intelligence. Big topic, but every organization is doing something in this field. Let's start with Ben. Maybe you give us some insight into your thoughts.
Sure. So the whole realm of AI, machine learning, one of the things that I did years ago when I was at the University of Chicago is we looked at this area and we understood that in order for us to tackle that, we need to have an orchestration of data pipeline. It's like a spinal cord. So they can then feed data to whoever needs it. It's like in a technology world, it's called enterprise bus. And so we looked at tools and we deployed tools as an infrastructure first. And then we started looking at use cases. So for AI machine learning, one of the things back then we did, and even now at Sinai we're working on, is a simple thing like radiology notes. And we were able to, using NLP, if a radiologist types in for an ER patient who comes to an ER that there's a nodule in the lung, we were able to extract that and be able to notify the PCP, the ER doc, to schedule an appointment. So that was a simple example of that. The other thing we did is we orchestrated telemetry data, lab data, to predict cardiac arrest. And that was the first time back then I understood the difference between cardiac arrest and heart attack. So that's what we did using technology, using AI, and now there's an IP out there for the whole algorithm. So I think from the AI perspective, the way we are going is we're going into algorithms first, and then getting into visual tools, deep learning to do pattern recognition. That's the way I see it. So we are right now into that mode of algorithmic mode where we're creating algorithms to predict, to solve, to take away the whole human side of, memory side of the story, repetition. So those are some of the examples that we have done. As I said before, we're also working on some of the other side of the machine learning where we can truly, from a revenue cycle perspective, for example, we want to identify the propensity of a patient to pay, especially when that patient has such a huge self-pay balance. So we're looking at that also from an administrative or revenue cycle standpoint. From a clinical standpoint, also we're looking at, as I said, that we want to see, one of the things that we noticed, that I personally noticed in radiology, the radiologists have a really nice way of their work. It's a work list. They work through that, and then they know what to do next. For a regular physician, I haven't seen that they have some sort of a work list to go through. So we're kind of using machine learning, trying to work on that, so that truly helps them go through the process faster.
Thanks. Sundeep?
Sure. So I think one of the areas that we want to try to stay as current as possible with is going to be with our EHR vendor. They're starting to develop more tools in this area, but it's still pretty early. So one strategy is just to make sure we stay current with all of what they're offering and understand how to use it effectively. We are working with a third-party vendor that is helping us with some of this now. We're still a little early in the stages, but one of the algorithms that they have built is to help understand which patients are ready to switch over from IV drugs, expensive IV drugs, to less expensive PO drugs. And we're finding some very interesting data in that area. But as I said, we're still a little early in the game, but definitely delving into that area. And it's a fascinating area, and it'll continue to be very insightful.
John?
Yeah, sure. I think where we've focused the most on with regard to predictive analytics is around care management. What we found, as a pop health company now, it is very difficult to produce an ROI through care management. And so we're trying to layer on predictive modeling to do more targeted care management interventions with those with multiple chronic diseases, and then largely focused on predicting those upon either a SNF or an acute discharge do require a more intensive care management intervention after the discharge. So.
Thanks. I will mention a tip of the hat to my colleagues at New York Presbyterian, where there are a number of AI initiatives and investments have been made by the organization. The one is in a project with a company on length of stay. So the data associated with discharge, the discharge process, is being fed into this data analytics program with a view to creating triggers for accelerating discharge appropriately. That is one that they're using. There's another one that they're using for workers' compensation documentation in the hospital, repetitive documents associated with on-the-job injury and workers' compensation reporting, where they've been able to create an algorithm to assist with accelerating that. So, and then one more that Ashish and I heard about the other night in a different venue, in the infusion center, they're using some work done by a different company in speeding up the turnover of patients between treatments, and that is also based on machine learning. So those are some examples that I'm familiar with. We've got a little bit of time left. Before I go to a question that we've got, perhaps there are some questions from the audience or some comments from the audience about any of these topics, whether they be managing large bodies of data, or physician burnout, or targeted digital innovation, or even AI innovation in either hospital or physician processes. If anybody has something that they think is interesting, would like to comment, would like to ask a question, now's the time, right? We've got microphones there. And then.
My question was about physician burnout. Y'all mentioned a number of things. I think anybody mentioned scribes and their assistance to the care team, and I wonder what there were any comments about that, or how to utilize scribes in the process.
We are looking at digital scribes as the next kind of in our innovation program. We're looking at, how can we use digital scribes, but we haven't solved the scribe problem yet.
Yeah,
Sundeep?
we have a few different models of scribe programs that we're experimenting with. One is the traditional medical assistant scribe, or a 2MA model, where the medical assistant is the scribe. The second one is a pilot with Google Glass, where there's a virtual scribe overseas, and the physicians, I think that the learnings from the various programs that we tried are that there's not one program that fits everybody. So I don't think it's for everyone. Not everybody is comfortable with that workflow. But for certain physicians, we've found that each one of those makes them more productive. I think the way we've approached it was, we've got one group of physicians who are already very productive that we want to support and prevent them from getting burned out. So we would offer them scribes. And then we have another group of physicians who are not very productive, but we want them to be more productive. So in those cases, we try to set certain expectations for them to maintain the scribes that we give them.
I have two questions. One is around the largest and major electronic medical records companies out there, vendors. How much do you think they're contributing on a regulatory level to push best practices? And how much best practices is really part of this physician burnout? Because, is it 30 or 40% of medicine is evidence-based? And a lot of it is based on your experience and how much you've seen and how much, really know the patient in that particular case. And then you find those large EMR pushing best practices that would make that physician sitting there, or provider, thinking about, I have to do it this way, but I think a better way to do it this way, but I need best practices or scorecards or things of that sort. The other piece of this is the documentation. How much do you think, moving forward, we should really minimize how much a physician or provider would have to document, because everything is in the electronic medical record, or we still ask for those labs to be, being documented there, reviewed, and this or that sort. How can we push from an expectation regulatory perspective to make just the documentation necessary for that provider who's an expert in that particular area, something that no one can do but that particular provider can practice at the top of their license, and then everything else can be done by somebody else.
Anybody want to take that?
I can take it. Actually, I just thought of a great use of AI just while you were talking. I think the best use of the AI will be to look at all the best practice alerts which have been firing, and majority of them which have not been clicked, and take them out of the equation, right? So we have done it manually. Kaiser has done it manually, but I think that's a perfect case of AI. Real time, it can train itself, right, and give an alert. I think I can talk about Epic experience. I've been involved with that since '99. First, Epic does provide a capability of 3 different kind of alerting system, and you can set the stage at that level. So you can actually decrease the level of alerting, fatigue alerts, and you can customize other alerts as well. The challenge is most of the people who are implementing Epic don't have capacity or a designated person who is looking at those best practice alerts and the click rate and those kind of things. So inevitably, even though the feature is baked into it, no one is leveraging that feature to adjust that. So I think it's a capacity burden which we see. So we blame EHR, and that's fine. I love blaming EHRs, by the way. That's my job, actually. But truth being told, we are barely using 25-30% of the features of EHR, right? I mean, if you talk about just using audio-based kind of report writers, that's built into most of the EMRs. We don't even use it, and then we keep on blaming those things. The second part, I think I forgot the question you were saying was, can we minimize the documentation? It's very interesting. What if we were completely ACO, and we were not paid fee for service and just on value? This is an old habit. It's a bad habit which EMRs created, that we have to document that much because it's a fee-for-service world. In an ACO world, I can just type 1 or 2 things, and that should be fine. But we haven't changed our habit for that. So that's, I think, something to ponder about for us as well, as we're thinking.
I think from an Epic perspective, I know Epic is now pushing most health systems to go back to the foundation model. And because that's where they've built all the best practices, and they're really pushing it. And I personally know a couple of health systems who are now going back from a customized EMR to back to the out of the box or the foundation model. It's going to take them a year and a half. But this is from an Epic perspective, they're pushing so that everybody's on the same platform using all the best practices. And I think some of the documentation is related to how the reimbursement is done. So you have to go back to how the insurance companies and how CMS pays. And I personally know, because when we used to work with our compliance department, and we used to make sure certain, in the template, there's certain sections were mandated to physician to fill it out. So it's because of how the reimbursement works, I think.
Yeah, I think in terms of the documentation piece, as much as the coding, unfortunately, is driving a lot of this, I think there's still a lot of physicians out there who don't understand coding well enough, and they still believe that putting extra stuff in your note helps your coding without understanding really the few elements you really need to support the coding. And because of that, we get note bloat and all these other things. So I think the key is going to be to go back to really what is the primary purpose of the note, right? Coding is one of the purposes, but shouldn't be the primary purpose. The primary purpose is a communication tool to yourself and to your colleagues to understand the care of that patient. So put the coding aside, and if you focus on that and educate people, if you have to do the coding piece, because we're still in this type of payer model, then make sure they get educated in terms of what really helps support the coding rather than the more you put in there, the better.
Sundeep, I think you hit upon a point I was about to comment on, but you nailed it. I think that probably best practices for billing and compliance aren't always best practices for clinical care. And as you just said, in the U.S. system, we're very dependent on that revenue model. And a lot of our electronic systems are synonymous with that as best practice. I think you touched on a major factor for burnout. You guys have hit upon a number of really great interventions, and I hear things like 40% reductions in CHF readmissions, $1 billion worth of savings for hemoglobin A1C, a number of other, reducing alerts, alert fatigue. Are you guys publishing these things, and how do you share best practices? What are the best practices to share best practices, and how can we get better at that? Because I know a number of you come from academic places. It's really hard once you do these interventions, you're on to the next intervention, and I wonder if there's an infrastructure to share this and get the word out other than conferences where we talk to our colleagues. I just wonder what you're doing in that space.
Happy to take that. I think that's a need we have identified. As we started our innovation center journey, we said, whom do we talk to? Like, we are duplicating each other's work left and right. We call it death by pilot syndrome or pilotitis, right? So anytime a startup company comes, I say, I have to prove it, because the person who proved it, I don't know what you did with that pilot. I can't even trust that pilot. And the only way for me to judge right now a startup company is to go to their website. Oh, that looks good. Maybe that's worthwhile for us to engage. We have to move beyond that, right? So because there's no FDA governance on majority of these things, we have to create some governance ourselves. So this need came 3-4 years ago. So we partnered with HIMSS, PCHA group, to set up a 32 health system consortium called as Node.health. It's now a nonprofit consortium. It just became a society for digital medicine. And the goal is to share and learn from each other all the stories. So we have a bi-weekly consortia call where we share what we are doing and we publish all the stuff. We also went ahead and created a journal called Digital Biomarkers with Karger Publishing in Switzerland. So we published a lot of our stuff on Digital Biomarkers journal. And then we created a newsletter, monthly newsletter called Evidence Pulse. And this is the first peer-reviewed innovation newsletter. So instead of hearing from the startups and Google or whatever on big, hairy, audacious stuff and kind of shiny objects, we really bring out the things which are published or which we truly believe is actually evidence-based. And now it has a member audience of 7,000 people just in the last 1 year. So I think we're taking steps to actually build a ecosystem which is built on evidence and not just based on what one company may have done we may not trust per se.
The other thing I'll add quickly is in our organization, because we are a private practice model, we work with so many different EHRs, we have a tendency to force best practice just by taking what does each EHR company do well, and then making the other companies sort of do that as well. And then of course they can go sell that, make a lot of money, but it's largely Athena, ECW, NextGen, GE Centricity. They each have positive aspects, and with our data partners, we'll sort of take what's best for the physicians, what is the greatest way to reduce their hassle factor, and then ask the others to try to replicate it.
Also, sometimes the vendors are also part of the mix. I'll give you an example of a PACS vendor that we worked, and we call closed-loop imaging. We were able to push lab data directly into the CT scanner, and these are the creatines of the world. And we optimized the CT scanner prep time from 30 minutes to 5 minutes, and less than 5 minutes, and that increased the throughput and the utilization of the CT scanner. And over the 5 years, we did not order more CT scanners, and that reduced, that PACS vendors, P&L. And now, from a volume to value world, that PACS vendor are now going to offer what we develop as part of their product, so that they can sell that as how this will reduce their capital investment. So sometimes it's also the vendor.
All this stuff we're talking about requires action, requires accurate and trustworthy data. And given how disjointed our system is today and how clunky it is, two-part question. One, have you guys put in place a data governance program within your institutions? And two, if you have you ever profiled your own data to look to see what the data says?
So we've been doing this when I was in Cleveland Clinic and here as well. It's again the bandwidth capacity, right? It's very tough to do data governance on nearly everything. But the key things like medication reconciliation, problem list, and those kind of things, you will see the same. When I order colonoscopy, after 10 years, I see the same colonoscopy prep which was given 10 years ago in the list. So I think we need to do more of that. But I want to kind of build on your question to say, we're not doing in this old data world, which is EHR. We need to do 10x of that in the new data world, which is all the data that's coming from patient-generated data and the machine-generated data, right? If there's a machine-generated data on blood pressure, maybe it's my wife and not me who's using it, right? So there's much more need for data governance with this new data world. And there's a fragmentation of apps, fragmentation of all those devices as well. So we're working a lot on creating a platform called as a digital medicine platform, which will aggregate all of these and combine the data so we can run the same rules engine for validation rather than doing it separately for each app per se. So I would say it's a work in progress. I wouldn't say it's done, but definitely something we need to keep in mind.
It's probably got one, our time is up. One last question there.
Sundeep, you had mentioned patient-reported outcomes, and I'm sure all of you are addressing that with the CGR bundled payment input in getting that last year. But I'm curious to know, how does health literacy of each patient kind of make those patient-reported outcomes variable, and then how do you judge, come up with some kind of structure to compare cohorts and their input? How are you judging all these?
Yeah, I think we're probably still in the first stage of the evolution of patient-reported outcome metrics. So right now, I think it's mostly about making sure that the surveys are written in a way that they don't have room for interpretation, as clearly as possible at the right literacy level, that you'll catch 90% of your patients effectively. In terms of how we then compare going forward, yeah, I think I certainly don't have an answer to that, but I suspect we'll be dealing with that very shortly. Once this starts picking up, we're going to have to deal with that issue. But I certainly don't have an answer to that today.
Well, listen, we've come to the end of our time. I want to thank the panelists for great input, and thank you all for your questions and your participation. And with that, we're adjourned.
Absolutely. Thank you very much, gentlemen.